Good morning. Thank you, Priti, for your presentation. And thank you, Harry, and the organizers for the kind invitation. I will talk after Tudor, who introduced very well the artificial intelligence. So I cut some slides after your presentation. And, but I'd like to start with this about the definition of artificial intelligence, because everybody now is talking about artificial intelligence, but some applications such as ChatGPT that are relatively new, but follow many others that have been used for decades. What we can do with AI? We keep in mind this when we approach artificial intelligence, especially for the future applications. Functionally, tools can gather and collate big data, apply rules to complex data sources, learn, identify patterns in big data sets, and especially act and perform with helping us for performing procedures, for performing literature, writing, and so on. It's very interesting. I go to the our application in pulmonology and in interventional pulmonology. At the present, we have some application. I will describe 5 applications. The first is on navigation. We use many navigators for some years, maybe 10 years, that is based on artificial intelligence. And regarding my topic, that is the training, now with this technology, we can enhance and improve the efficiency of bronchoscopy training, especially for novices. A practical application is this. This is a normal virtual reality simulator with artificial intelligence, and it was studied with a randomized study that demonstrates an improvement on diagnostic competency, on navigation, and in reduced procedure time. And this is available now in the market. Another application could be the evaluation of the EBAS image, especially in the staging of lung cancer, non-small cell lung cancer, to differentiate between benign and malignant targets with better accuracy than in the present. Unfortunately, currently there are no commercially available artificial intelligence-based systems. Maybe you are studying some here. There are the most experts in the world, but for the moment there is not. But with the increased computational power of the computer now, we guess that in the near future we will have this system. Another very interesting is the evaluation of the rapid on-site cytology, especially to help interventional pulmonologists in settings where there is not the possibility to have the cyto pathologist on site, improving accuracy and also reducing the costs. In nodule management, we have heard before the radiologist, and we know that can probably help to rapidly identifying lethal cancer with the CAD system, predict nodule malignancy, and also predict prognosis and grade malignancies. Another application is on radiotherapy. Radiotherapy now is applied, artificial intelligence is applied especially for the cure of prostate, for head and neck diseases, but there is an increase in interest also in the lung. Only 4% for the moment in comparison to 42% for prostate, but is increasing. That are the applications for the clinical application, but there are very, very interesting applications also for research and writing. We have not only ChatGPT, we have heard from Tudor, there are other new applications. I list some applications for general research assistance. I don't describe in detail, but you can find, so this conference is recorded and available with Pulmonology on Air. So you can find all these new applications for general research assistance and especially for research and literature review tools that are used especially for the pharmaceutical companies, for the, to review the literatures, accelerating the process to produce new drugs, but are very, very interesting also for the scientists. This is the list. Very interesting also the help for writing and editing. But going to my topic, that is training, the application of artificial intelligence, augmented reality and virtual reality in interventional pulmonology training, helped a lot for the pathway of training. This is the track to competence from novices to competent interventional pulmonology. The second step is to develop training pathways and methodologies. And we had 5 years ago a very interesting consensus in Venice where some of you were invited. It's very interesting, the conclusion of a Harry Cole, that is a guru of training interventional pulmonology, that concluded that patients must not be used as subjects for medical procedural education. So we have an increasing availability of robust alternatives, and especially simulation, with the use of computers to, especially with the high fidelity that produce experiences extremely realistic and provide high level of interactivity and realism for the learner. We used simulation for many years in the Master in Interventional Pulmonology in Florence, and we tested many high-fidelity simulators. The most popular is the Bronch Express and the Bronch Mentor. Now it's very interesting, the Endomentor suite, because is very useful for not only for pulmonologists, but also for gastroenterologists and urologists in our hospital. We bought this system to save money and have one tool for three specialties. In particular, for the interventional pulmonology, we have a module of virtual reality for the basic bronchoscopy, diagnostic bronchoscopy, for EBUS, but also for emergency bronchoscopy, and a chest standardized curriculum for all the pathway of the training in interventional pulmonology. And it's very interesting also the OSIM system that we use in our training because it's very interesting for intubation, for difficult intubation. Every new procedure needs a new simulators. This is an example of the virtual reality simulator of ion robotic bronchoscopy. And the future will be immersive virtual reality. This is provided by Michael. Maybe Michael is here. And it's very interesting to simulate realistic situation of the bronchoscopy suite. The studies demonstrate since 2001, we recalled the efficacy of the virtual reality, and because accelerate the learning, the apprenticeship, and preventing also error and mistakes especially for the novices. In our master, we use pre and post evaluation with simulators. It's very interesting that we demonstrated that when we achieve the 80% of competency, the simulator is no more useful, but you can go to the patient with the supervision. So it's very useful to know when to go to the patient. Augmented reality. This is a system that we use in our master, and augmented reality superimposes computer-generated stimuli on real world. That is me, that use this software to show, in this case, the anatomy of the lymph nodes. I go to the conclusion. Efficacy of virtual reality is demonstrated because it improves skill acquisition and time needed to complete the procedures, improve bronchoscopy training efficiency compared to the traditional apprenticeship model, affords learner tactile feedback and realistic 3D visualization. And, but the problem is that we have some limitation to the technology that we can improve, including reduced haptic fidelity compared with the mannequin. So it's complementary to the low fidelity simulation. And I conclude with this phrase that we are at the dawn of a new era in medicine when artificial intelligence and virtual reality begins its immersion into daily clinical practice. And physicians should not view this as human against machine, but a partnership in an effort to further improve clinical outcomes for the patient. Thank you very much for your attention.